For cervical flexion range of motion, we use the axis as the external auditory meatus, the stationary arm as the ceiling, and the moving arm perpendicular to the nose. Ask the patient to sit with good posture, and then try to touch their chin to their sternum. Ask the patient to first perform active range of motion, take the measurement, and then assess passive range of motion with overpressure. For cervical extension range of motion, we again use the axis as the external auditory meatus, the stationary arm as the ceiling, and the moving arm perpendicular to the nose. Ask the patient to assume a good posture, and then to look up towards the ceiling. Ask the patient to first perform active range of motion, take the measurement, and then assess passive range of motion with overpressure. For cervical rotation range of motion, we use the axis as the crown of the skull, the stationary arm as the starting position of the bridge of the nose, and the moving arm as the ending position of the bridge of the nose. Ask the patient to assume a good posture, and then to look over the corresponding shoulder. Ask the patient to first perform active range of motion, take the measurement, and then assess passive range of motion with overpressure. For cervical lateral flexion range of motion, we use the axis as the spinous process of C7, the stationary arm as the floor, and the moving arm as the external occipital protuberance. Ask the patient to assume a good posture, and then try to touch the corresponding ear to the corresponding shoulder. As shown here, the patient adds in a thoracic lateral flexion, indicating that he does not have any more range of motion within the cervical spine. Ask the patient to first perform active range of motion, take the measurement, and then assess passive range of motion with overpressure. For cervical flexion manual muscle testing, I ask the patient to assume a good seated position. I then ask the patient to gaze down towards the ground. After doing so, I use my resistance hand to resist flexion of the cervical spine, and my stabilizing hand to prevent accessory trunk movements. For cervical extension manual muscle testing, I ask the patient to assume a good seated position. I ask the patient to push into my resistance hand, resisting cervical extension. With my stabilizing hand, I prevent trunk accessory movements. For cervical lateral flexion manual muscle testing, I ask the patient to assume a good seated position. I ask the patient to push into my resistance hand into lateral flexion of the cervical spine. With my stabilizing hand, I am stabilizing the shoulder girdle. For cervical rotation manual muscle testing, I ask the patient to assume a good seated position. I ask the patient to rotate into my resistance hand. My stabilizing hand helps prevent accessory cervical movements, as well as assist with the counterforce. For an accurate blood pressure assessment, ensure the patient has been seated for at least 5 minutes. Select the right cuff size for the individual patient. Line up the artery mark of the cuff with the brachial artery. Stabilize the patient's arm around heart level. Adequately inflate the cuff, then slowly release the air 2 to 3 millimeters of mercury per second. With the stethoscope lined up with the brachial artery, listen for the first beat or the systolic pressure, and then the last beat or the diastolic pressure. For the C5 dermatome, we will be assessing the coarse touch of the skin over the upper lateral arm into the shoulder. Ask the patient to close their eyes or look away, and then nod when they feel a sensation. For the C5 myotome, we will be assessing the deltoid muscle. Ask the patient to push into your resistance hand, resisting lateral shoulder flexion. With the stabilizing hand, stabilize the shoulder girdle to prevent accessory movements. For the C6 dermatome, we will be assessing coarse touch over the skin of the lateral forearm into the thumb. Ask the patient to close their eyes or look away, and then nod when they feel a sensation. For the C6 myotome, we will be assessing elbow flexion and wrist extension. For elbow flexion, stabilize the shoulder girdle and ask the patient to perform a bicep curl as you resist. For wrist extension, stabilize the forearm and resist wrist extension with your resistance hand. For the C7 dermatome, we'll be testing coarse touch over the posterior aspect of the forearm into the third digit. Ask the patient to close their eyes or look away, and then nod when they feel a sensation. For the C7 myotome, we will be assessing elbow extension and wrist flexion. With the starting position shown here, stabilize the shoulder girdle and ask the patient to push his elbow out towards the wall. For wrist flexion, stabilize the forearm and resist wrist flexion with your resistance hand. For the C8 dermatome, we will be assessing the coarse touch over the medial aspect of the forearm into the fifth digit. For the C8 myotome, we will be assessing thumb extension as well as finger flexion. For thumb extension, stabilize the patient's hand and ask the patient to pull his thumb up towards the ceiling as you resist the motion. For finger flexion, stabilize the patient's hand and then assess finger flexion with the PIP and DIP joints to assess both the flexor digitorum superficialis and flexor digitorum profundus. For the T1 dermatome, we will be assessing coarse touch over the medial aspect of the upper forearm, crossing over into the lower aspect of the medial arm. For the T1 myotome, we will be assessing finger abduction. Stabilize the patient's hand and individually assess fingers for abduction strength. For the L2 dermatome, we'll be assessing coarse touch over the anterior and medial thigh. I ask the patient to close his eyes and nod when he feels a sensation. For the L2 myotome, we'll be assessing hip flexion. Stabilize the low back to prevent accessory movements. Ask the patient to raise his leg into your resistance hand to assess strength. For the L3 dermatome, we will be assessing coarse touch on the lower anterior thigh down towards the knee. I ask the patient to close his eyes and nod when he feels a sensation. For the L3 myotome, we will be assessing knee extension. In a seated position, stabilize the hip to prevent accessory motion. Then ask the patient to kick his leg out into your resistance hand to assess strength. For the L4 dermatome, we will be assessing coarse touch over the medial calf and ankle. I ask the patient to close his eyes and nod when he feels a sensation. To assess the L4 myotome, we will be performing ankle dorsiflexion. Stabilize the posterior ankle and ask the patient to lift his foot up into your resistance hand. For the L5 dermatome, we will be assessing coarse touch over the midline of the calf into the dorsum of the foot. I ask the patient to close his eyes and nod when he feels a sensation. For the L5 myotome, we will be assessing great toe extension. Stabilize around the base of the foot, being careful not to press on any extensor tendons. Ask the patient to extend his great toe into your resistance hand to assess strength. For the S1 dermatome, you can assess the lateral ankle, the posterior calf, and the plantar aspect of the foot. For the S1 myotome, we'll be assessing ankle plantar flexion. Stabilize around the posterior calf and ask the patient to press into your resistance hand. This part will explain the upper limb tension test 1 for median nerve bias. Allow the patient to get into a supine position. Ask the patient to tell you when he feels symptoms of neural tension, such as burning or tingling. The steps are shoulder girdle depression, shoulder abduction, shoulder external rotation, forearm supination, wrist and finger extension, elbow extension, and cervical side flexion. This part will explain cervical decompression as it relates to the Wehner's cluster. Ask the patient to assume a comfortable supine position. In this case, the patient required some light massage and movement in order to relax. You will then place the bottom hand directly under the occiput and the top hand directly under the chin. You will then utilize your body weight to perform a direct distraction of the cervical spine. It will be more comfortable for you and the patient if you are utilizing your bottom hand to do most of the work. As it relates to the Wehner's cluster, if this test is positive, the patient should see a reduction in their symptoms as you are decompressing the spine. This section will explain a PA glide of the cervical spine. I have the patient in a supine position and I'm palpating for the C3 spinous process. After I'm done palpating, I am able to provide a posterior to anterior force on the spinous process with my PIP joints. Again here, the patient requires light massage and movement in order to relax. Here I am providing a grade 3 mobilization, so I'm able to pick up the slack, Then move the joint from mid to end range. This section will explain the Ruse test, a special test for thoracic outlet syndrome. The starting position for this test is seated with shoulders at 90 degrees abduction and elbows at 90 degrees flexion. You then ask the patient to open and close his hands for up to 1 minute. This test is positive if the patient experiences heaviness of the arms, ischemic pain, numbness and tingling of the hands, and possibly discoloration of the hands. This portion will discuss the tectorial membrane test as it relates to cervical instability. With the bottom hand, you will grip the spinous processes and perform a distraction. With the top hand, you will grip the mastoid processes and pull with a posterior upward force. This test is positive if excessive translation occurs between the occiput and C1 and C2. In this portion, we will go over the C4 manipulation setup. Start in supine position. Rotate the patient's head 45 degrees. Find the spinous process of C4 by palpating down from the spinous process of C1. Palpate 1 finger breadth over to locate the facet. Provide a posterior to anterior force and put the head in slight extension. The patient's head should not come off of the table. If it does, you are providing too much force. When the joint is locked out, you will provide a high velocity thrust in the direction that the patient's head is rotated.